you'll know in probably about 4 to 6 weeks as they begin. She recovers function, you begin to see how far she'll go.
Your talk was just wonderful. My question is, I was just bowled over by the point that there are far more suicides than there are homicides in this country. And I wonder if these kinds of statistics are available in some written form, and also some of the things that you said about the new research and the finding of changes in mutations are also available possibly in annual reports of NIMH or other literature that you might recommend for the audience.
Well, you don't have to go to an annual report. Those are deadly. You really don't want to read those. I don't even want to read those. But if you go to our website, which is nimh.nih.gov, .nih, because we're part of NIH, .gov. All of this in much more in a very easy to access way, including videos and all that stuff that we do nowadays. I even have a blog, which I never thought I would do. Yeah.
I wonder if we could come back to a point that you approached but didn't quite reach, and that is early intervention of psychiatric illness. I think autism is a nice paradigm of where we might go, because my colleagues tell me that early intervention does make a difference, and now we've set up algorithms to be able to detect which kids are at risk, and then there are referral networks which are incomplete but there to evaluate these kids and see which ones need further therapy, which ones can just be sent back to their doctors. Now, in terms of other psychiatric illnesses, where are we compared to where we are with autism? It seems to me, pediatrician, that this would be an important point of intervention, and the corollaries are people trained to do this sort of evaluation, and would there be a network to send them to?
Those are great questions and points. You remind me that I probably should have stressed a point that I didn't make very clearly in my remarks, and that is that one of the maybe subtle implications of saying that these are brain disorders is that it means, in a sense, that the behavioral manifestations are the last thing that you see. And we know that. In Parkinson's disease, you don't get the rigidity and tremor and the slow movements, all of that stuff, until you've lost 80% of your dopamine cells. So it's the very last thing to emerge is the behavior. That's true. In Huntington's, it's true in almost all brain diseases. We haven't thought that way. And that's why, in response to another question, I made the claim that in schizophrenia, for instance, where the psychosis is at age 18 or 19 or 20, or perhaps in this case we heard about it, 21, 22, that it's very likely that that is the last stage, or one of the last stages of the illness, and that we have to find a way to begin to detect the changes that take place much earlier, so you preempt that. And the way that happens is through understanding that if these in fact are brain disorders, then in developing biomarkers, developing ways to screen for that doesn't show a huge burden on people, and yet helps to detect who could be at risk, and then creating both the family supports and all the other things that people will need to make sure that the behavioral part of the illness doesn't actually develop. We do this for heart disease all the time, right? We prevent myocardial infarction. We are thinking a lot about early intervention then for all of these, but first we have to be able to detect the early states of risk, and we're not there. We're trying to do this in autism because we know if you have a brother or sister with autism, you've got an 8-fold higher risk. Schizophrenia, the risk isn't that high, although it is higher. And that's part of why we're so interested in the genetics. We think that the genetics, and soon every one of us in this country will be able to get a genotype easily, that would be one of the ways in which we could kind of lay out what is is this person got the risk architecture that even puts them in that general area? It's turned out to be more complicated than we thought, but that may not be as helpful as we thought. Eventually, it may be that there'll be some way that all of us will get some kind of a brain scan at the same time that we get our normal pediatrician visits. And seeing the differences between age 1 and age 3 and age 6, there may be trajectories that say, hey, just like we do this for height and weight, this is somebody we ought to be looking at. And if their weight's way off, you talk to parents about changing diet. Or if their height is way off, you look at, is this a growth hormone problem? So we maybe need to do that for brain development, and we haven't.
We'll take just a few more questions. Before we take any, let me call on people, I think. Let me urge those of you who are not staying till the very end to do two things. First, we bought you breakfast. If you are moved to do so, you might help us defray the expense. As you leave, there are bread baskets. Secondly, and equally important from our perspective, if you're not on our list or you haven't heard from us lately directly, please be sure we have your email address and your name, and you can sign up as you go out. I'm going to exercise the chair's prerogative and call on Kate Bennett in the back of the room, please. Wait for the mic.
I was interested in your comments about the mental illnesses largely being developmental issues, and I understand that's the case, but it was not my understanding of depression, which I thought was more of a middle age to later onset. And I wanted you to speak a little bit about what's happened in decades in which we can scarcely think that there might be large genetic changes, and also ask if you think there's a difference in childhood suicide, which might be a result of impulsive behavior, versus adult suicide from depression.
Right, both great questions. So you're right that the depression, major depressive disorder, usually has an onset in the 30s for the first episode, although many people in the 30s will talk about something that happened much earlier in life, usually in their teens or early 20s, when they had something that sounds like a smaller version of the same thing. What has been surprising is that there's a very, very high rate of anxiety disorders in people who later develop depression. And we used to say, well, maybe this in some way puts them at risk. I think today we think more that it's the same illness, that what shows up as anxiety at age 8 looks like a mood disorder at age 38, but it's probably the same process. And we're wondering if we did a much better job of treating anxiety with cognitive behavior therapy, maybe medication, at age 8, would it actually vaccinate somebody against developing the mood disorder 20 years later? We don't know that, but that's a reasonable question. On the second question about suicides, you're right. It's a very difficult problem. Suicide amongst, particularly with adolescents, where it's depending on how you look at it, second or third leading cause of death in adolescence, is very frequently impulsive. And it's ridiculously difficult to try to prevent that. There, the best thing you can do is to think about access. So barriers on bridges, if you can't get rid of guns, get rid of ammunition, whatever it is that you can do to remove access. But there's a limit to what one can do in that sense. That's less true for adults, and particularly, the highest rate of suicide in America, besides the Native Americans in Alaska, which have probably the single highest rate. But for the rest of the population, the highest rate, amazingly, is in white males over 60. And that's usually premeditated, carefully planned, often ruminated for days. 75% of them have seen a physician within a week, but haven't usually mentioned this, haven't mentioned their suicidal thinking. So there, the right intervention might be to really work with the family docs and internists to help them to realize the risk that's there, and that somebody who comes in with poorly defined concerns and complaints and maybe back pain or something like that, who's living by himself and who seems to have very low energy and less interest, that's probably where you want to ask the question, and it's not done.
With the events in Tucson on my mind, and I'm a practicing psychiatrist, I keep thinking about our civil commitment laws and how inadequately applied they are, and how in this situation with all of the red flags, this event may have been preventable at that moment anyway. And I wonder what you think about strength. I feel they should be strengthened. We have an ethical dichotomy between autonomy and paternalism, and we've gone in my view, too far from severely mentally ill, psychotic people in the direction of autonomy, when we should be moving back toward paternalism.
Yeah, this is such a tough one. That's what I was mentioning before. I think we're always struggling to find the right balance. But I'll just want to make sure we're clear on this, that while this event in Tucson, really brings this question to the fore, you have to balance that with the knowledge that the vast majority of people with serious mental illness never do anything like this. And the vast majority of people who do something like this don't have a mental illness. So it's, you've got, most homicides have nothing to do with schizophrenia, and almost all schizophrenia has nothing to do with homicide. Right.
My question is, for the society, why aren't we using the laws we already have?
Yeah, so in this case, could something else have been done? As far as I know, he was never seen by anyone who would have been in a position to actually talk about involuntary treatment or involuntary commitment. The school had a lot of concern. People were concerned, but if you're a psychiatrist and you know what this is like, you see people like this all the time. I mean, I work at St. Luke's House, which is one of the great things about Montgomery County. It's a real jewel that we have here. Is we have a great local system, nonprofit, for serving the needs of people with serious mental illness. If you live in that world, you see people who are eccentric, who have crazy thoughts, who seem to most of us, who are frightening. But you know what? They don't need to be locked up. They do okay. And we've all, learned to live with them and to serve them and help them. And that feels humane and it feels good. I think this is a tough one. And you don't want to make policy based on one bad event like this, but it does force you to ask about, do we have the right policy? Could we do it better? How could we prevent this from happening? And I think this is a great public conversation that all of us ought to be having at this point, rather than just pointing to whether this is the Republicans or the Democrats who are at fault, which is kind of where the discussion went for the first 3 days.